next speaker, and the last this afternoon, is Peter Tugwell. Peter's professor of medicine and epidemiology and community medicine at the University of Ottawa, and he's a practicing rheumatologist. He received his medical degree from the Royal Free Hospital Medical School in London, and subsequently worked in London, in Zaria in Nigeria, and at McMaster for a number of years before going to, I say going to because I was at McMaster when Peter was there, going to Ottawa to become Director of the Center for Global Health and Chair of the Department of Medicine at the University of Ottawa. His research program and multidisciplinary team around his Canada Research Chair in Health Equity. The goal of this program is to improve the health status of the poor and middle class and reduce socioeconomic inequalities in health through facilitating the summarizing and dissemination of systematic reviews of educational, health, legal, and social strategies to reduce inequitable inequalities in health in individuals and populations. Peter's topic is non-randomized studies in systematic reviews, including those on equity issues. Peter?
Niagara Falls, what a perfect place for a Sackett Symposium. I arrived from Africa many years ago in the early 70s and was a junior colleague in CEB and was told that there was an annual retreat. Where else? Niagara Falls. And I was just trying to find the pictures of Brian Haynes, Dave Sackett, myself, Mike Gent, sitting behind the barrel, pretending we'd been thrown over the edge of the falls. So it's great to be back, in a combination of both serious science and having some fun, certainly pervaded today. Apologies for not being here yesterday. So I took the opportunity of this invitation to just reflect on the positive sides in terms of the credentials, badging, but also the hazards of coming from McMaster and being a colleague of DLS over the subsequent years. And nothing could be more appropriate than a battle between RCTs and observational studies that has been going on with a robust interaction over the years since I left McMaster. So for various reasons, and I blame many people sitting here in this room, I ended up being a totally unofficial convener and broker within a variety of situations of these battles. And so I'd like to share with you some of the experiences from that. I particularly want to say a big thank you to the group in the Cochrane collaboration, having been invited to be involved way back from Ian Chalmers, but then subsequently over the years being involved initially with the musculoskeletal group, and I'll use some examples from that, and then more recently the opportunity of working in the field of equity. Working with a group of non-randomized studies, particularly George Wells, a very close friend of mine, and Barney Reeves, who've responded to challenges. Because as a coordinating editor of a group in Cochrane, suddenly there were these multiple requests for how to handle non-randomized studies over the past few years. And this was compounded within the equity arena with some groups who felt that maybe the Cochrane collaboration and the Campbell collaboration were not listening. And a proposal came out from a very prestigious institution to set up a third collaboration because we were not listening about non-randomized studies. So I'd like to just share with you some of the highlights and the experiences. Phil Davies, who a number of you will know from his work in the UK in the Cabinet Office and then in the Campbell collaboration, put together this whole series of the fact that Cochrane and Campbell started off with looking at synthesis of intervention effectiveness of what works, But increasingly, we're being asked to tackle these other approaches, which is the synthesis of implementation effectiveness, knowledge translation, synthesis of resource effectiveness. We have a group on economic evaluation, synthesis of experiential effectiveness, users' views, qualitative research, and more recently, the equity group. Again, all of the good things that happen there go to the credit of someone called Mark Pettigrew, who is just a phenomenal, very serious thinker in this. This has resulted in a group of us who have been brought up in RCTs. How are we going to address this? And initially it's sort of a defensive approach, but over the time we realized that we really needed to sit down and have these discussions. So it's ended up with some really very creative tensions. Again, the question that comes up that came up in some of the table discussions today, are we really just randomistas, or are we prepared to take a more Catholic view? So let me take you through some of the debate. So some of the issues that come up is, well, as Cochrane's only interested in RCTs. How many of you have seen this review? Perhaps the most commonly cited Cochrane non-randomized review is that for pool fencing preventing drowning of children in the year 2000. 3 case control studies met the selection criteria, a very large effect, and showing that isolation fencing is definitely superior to perimeter fencing, and coming out with a strong conclusion on the Cochrane Library. Most recently, a number of you were with us in Quebec at the 20th year celebration, and Jos Verbeek presented a study there looking at 202 Cochrane reviews that contain non-randomized studies, including quasi-RCTs, CCTs, controlled CBAs, interrupted time series, cohort studies, case controls. Again, making the comment that we're all at sea and we need desperate help with the risk of bias assessment, and I'll come back to that, and David and Holger have already mentioned it. So I've had a number of discussions with Ian Chalmers around this, most recently a little while back, traveling for many hours on the terrible roads around Croatia. And those of you who know Ian, he never gives up. He points out that systematic reviews are themselves observational, that on his gravestone, he doesn't want anything about RCTs. He wants something about systematic searching and evaluation. He uses them in many of his evidence-based talks, and those of you who've seen him have seen this wonderful series of slides of the Spock book, where in the old days everyone asked for their babies to be laid on their front so that their skulls would not get deformed, and then they were carried out with this great interrupted time series showing a dramatic effect in Australia of the Reduce the Risk campaign. The EPOC group, Jeremy Grimshaw and colleagues, have all along accepted non-randomized designs, and Andy certainly is most well set to comment on this, accepting CCT's ITS CBA. And then I don't know if Jan van der Broeker is still on the line. Do we know? Okay. So I was at the meeting Richard Smith convened, and he took me for a long walk and asked whether in fact we were prepared to interact with the pharmacoepidemiologists. That resulted in a subsequent meeting with Paul Glasio and Ian Chalmers, ending up with a nice paper in the BMJ. And then he gave a very nice conciliatory talk in 2009. Subsequent to that, we've had some very long emails around whether in fact we're continuing to be serious about this. But all credit to him, he came to the Oxford meeting most recently again, and has been a major contributor to this. He precedes me as an editor for the Journal of Clinical Epidemiology, so I'm very much in his debt in many other ways. And then more recently, Barney Reeves and George Wells were persuaded to hold a meeting in Ottawa on non-randomized studies. And then we took it further with some further discussions with the PRISMA extension for equity. Again, there's a lot of this deliberative dialogue and building relationships of bridging across to the other disciplines of epidemiology, social science, and economics. And then in March, there was a meeting that David, I think, was referring to, and David had an enormous influence on that meeting, and I'll come back to one of the key elements coming from that. And then most recently, there's been more meetings in Quebec. I seem to go around the world. I thought that I would no longer have to travel. In terms of building relationships, there's absolutely no alternative to actually being in rooms such as this with body language. And unfortunately, the world hasn't changed sufficiently with the digital age that's had a chance to change. And this third collaboration group are sort of hosting a meeting in November, where we're going to have a big debate about quasi-experimental designs and what that includes, and whether that really has to be under the control of the investigator or whether instrument variables, propensity score, etc., can be used. The fifth sort of issue activity that's happened is that the public health group have become increasingly prominent, not only in their own review group, but across a whole series of review groups within Cochrane, where a lot of the upstream interventions are not currently have any data from RCTs. And the example that Nancy Centesso, thank you Nancy, and Holger from the meeting we had earlier this week in Quebec, the helmets versus no helmets for motorcycles, I think was the only one that got through the Gordon Guyot filter of him standing up, said, yes, I believe it, where the helmet shown to reduce motorcycle injury and head injury. Ian Roberts' group has done a very nice study of 61 observational studies, again with a large effect. Again, the message getting through that there are studies out there that's important to summarize. And this is the SOF table that Holger's has explained. The sixth issue came along, and again, Andy Oxford takes a lot of credit for this, for forcing us within Cochrane to not only just put out reviews that include benefits and many of those situations where there was RCT evidence, and forcing us to look at the important questions that clinicians and policymakers and consumers were asking to balance the benefit and the harm. Holger's covered the grade. A more recent thing that's just happening, and I don't know if you've heard about it, is a thing called the Cochrane Patient. It's just been initiated, led by Dawn Stacey and Annette O'Connor from Ottawa with a lot of other people, where they have come up with criteria saying when you're presenting information to patients, it's really very important to balance it, and by all means say whether it's strong or weak, but make sure you present it on both sides. And so we've been trying this out with a series of different formats. This is in the BMJ, of the benefits showing in green, and then the harms coming from in red. But again, things like TB and fungal infections from the biologics come from observational studies, and again, finding ways of presenting that appropriately. Seventh issue is that there have been some new initiatives developing both within the Campbell collaboration and in the Cochrane collaboration. I've been very closely really involved in supporting the Equity Methods group. You'll recognize Andy there in several of those pictures, and introduced me to some wonderful people, and particularly want to point out Mike Kelly, who again has been quite remarkable in brokering and bridging across. And so we set up this, again, Mark Pettigrew, again, has got the credibility in the area, I don't, to set up this group to try and bring the equity lens on what we're trying to do, to focus the equity lens on Cochrane reviews and say what works in the disadvantaged. I think it's nice just to clarify equity is a fuzzy area, and so it's really nice, and the easiest definition that I find useful is that you need three criteria. Number one, there should be a difference in health outcomes or health risks. Number two, it should be potentially avoidable. You do something about it. And number three, if it's inequitable, it's unacceptable and unjust. And then focusing in on those areas where we can actually do something about it, I think is the chance for us to actually make a difference. So as a result of Annie introducing me to Mike Kelly, I was asked to go to a meeting following a situation where there had been Michael Marmot and the Commission had held a meeting whereby the people involved in Cochrane had walked out of one door, the people involved in qualitative research had out of another door, and pharmacoepidemiologists out of another door. So there was a standoff, and Mike Kelly was brought in and did the most brilliant job in saying if you're part of this, you stay in the room, even if you disagree, you don't leave. And was a wonderful situation of collegial respect that I take my hat off, and came up with an interesting series of discussions which led to the criteria which we use in our group, which we put in the BMJ. A big emphasis there was study design, and again, Mike Kelly arguing, please avoid the word hierarchy if you can, avoid the word pyramid if you can, and sticking with nondescript terms such as fit for purpose allows us to go forwards. A result of this work is going to end up with a new chapter in the Cochrane Handbook relating to these criteria, and is linked to some of these reporting guidelines where in PLOS Medicine came out with the extension for equity of where it's appropriate, really please do make sure that you think about those disadvantaged, because in the past in Cochrane we tended to average everything out. We haven't tended to separate out, are those disadvantaged really benefiting? The next thing happened to me was the opportunity to be invited to work with someone from the evaluation unit from the World Bank to set up a new group within the Campbell collaboration. Campbell collaboration, as you probably know, looks at crime and justice, education, has a methods group, social welfare, and a user group. Someone called Howard White, who was at the bank, was asked whether he would be interested in getting involved in this. And so I was asked to come in and sort of provide the unofficial brokerage again with which has been an incredible experience for me working with developmental economists. They have a totally different approach to the way the world works. And getting involved in issues like farmer fields, getting rid of pesticides and how do you increase productivity in crops, the way in which water should be purified at source or by hand washing, issues around the HIV epidemic, and the whole issue of what happens in the community, things like governance. Again, can one apply the same methods across this, or do we need a separate collaboration to look at it? I think the answer is resoundingly yes, we can do it if we work together, and come up with some articles already developing this. And then more recently, the last item on this list of 8 is that at the Cochrane meetings in the UK early on, Sally Davies, who was very involved in funding in the UK, challenged us not to be too purist and to be much more open to this. And David Tovey has now come out with an official statement that relevance prioritized the question, not the method. So quickly, in the last couple of minutes, responses to the requests for this, and again, some of this is already being covered. Number 1, the Cochrane Handbook is being revised with a sense of urgency to address the increased demand from inside with this non-randomized meeting where we had. Being published in Research Synthesis Methods for those of you who want to see the series. There was these issues that came up around how to handle it with systematic reviews. I don't have time to go through it in detail now. I just want to get on a couple of other things. The sort of issues that came up there, can we be more explicit in guiding authors on what might be gained? Tremendous cry for help from the coordinating editors within Cochrane. The bottom line is that for many public health reviews, there's just no RCTs. Yes, they should be done, but they haven't been. Providing guidance requires not only statistics, and that's why, as a sense, it was all for the statistics section. It needs to be pulled back into the general methodology section, and came up with a series of recommendations. So I just want to finish by commending Holger on the very nice paper at the end there, which has come up with an algorithm which we're now trying to test out amongst the coordinating editors to actually try to decide when, in fact, we should do and include non-randomized studies in our systematic reviews. We clearly can't do it on them all, and so we need to start out with a few. And so we're in the process of testing that out with Barney Reeves and George Wells. And lastly, I just want to introduce you to this idea, again, picking up on what David said earlier. It'd be very nice if there's some way we can show the risk of bias at the same as the forest plot. And so we're playing around with different formats now to do this both for RCTs and non-randomized studies. And there's this group that David mentioned, and he gets a lot of credit for particularly coming up with this concept of the targeted RCT, which allowed all of us to come together. And in an ideal world, what would a target RCT look like? And then let's get a sense of how we do that. And here's the proposed tool, which will be worked through a number of different formats. The other thing that's coming up in this is selection bias keeps coming up in those discussions that worries all of us with observational studies. And so adding not only a serious risk of bias, but a critical risk of bias, if we're really worried about selection bias, allows us to put it together with the randomized and the non-randomized all on one picture. So a few things are just happening in the works. This is an incredibly fast-moving field. There's a thing called risk of bias in systematic reviews, which another series of individuals are trying to go generic across not only interventions but diagnosis and others. There's the Harvard quasi-experimental meeting, and then I didn't know about the PCORI initiative, which again I think we need to come together and all talk. So these require a whole new set of skills. The people in Cochrane collaboration frequently don't have them. And how do we do this, and how do we do this right? Thank you so much.